Axoplasmic transport. Axons are long secretory processes. Substances produced in the cell body of a neuron require an intracellular transport system in order to reach the axon terminal. Substances travel to and from the soma along microtubules, also known as neurotubules. These neurotubules are held together by tau proteins. That's very important to remember when we cover Alzheimer's disease in neuropathophysiology. Transporting substances along the neurotubules intercellular roadway requires two ATP-dependent motor proteins called kinesin and dynein. Kinesin transports substances away from the soma, referred to as anterograde or also orthograde transport. Dynein transports substances towards the soma, referred to as retrograde transport. Anterograde fast transport. Anterograde transport can either be fast or slow. Fast anterograde transport moves about 400 millimeters per day. To put it in perspective, it takes 2.5 days for synaptic vesicles formed in the cell body to reach the neuromuscular junction in a person's foot. Anterograde fast transport carries products such as mitochondria, phospholipids to maintain the membrane, membrane-bound organelles, enzymes necessary for transmitter synthesis in the axon terminal, and large molecule neurotransmitters. It transports them from the soma towards the axon terminal. Anterograde slow transport moves about 1 millimeter per day. So to put that into perspective, it can take up to 3 years for substances produced in the soma to reach the neuromuscular junction in a person's foot. Anterograde slow transport carries proteins and polypeptides and substances dissolved in the cytoplasm inside the vesicle from the soma towards the axon terminal. Retrograde transport moves about 200 millimeters per day, so it can take about 5 days for something to reach the cell body from the terminal end of an axon. Some of the things retrograde transport carries back to the cell body are old organelles and vesicles to be digested by the lysosomes in the cell body. Vesicles at the terminal end of an axon sometimes take in substances called nerve growth factor via endocytosis and carry it to the cell body by retrograded transport. Unfortunately, retrograde transport is also one way some viruses such as herpes simplex and herpes zoster, rabies, and poliovirus travel to the cell body of a neuron. Axon damage and or degeneration can occur in either an anterograde or retrograde direction. Degeneration of an axon starts to occur approximately 24 hours after the injury with infiltration of microphages to clear the damaged tissue. The rate of degeneration depends on how close the injured site is to the soma and the number of, if any, axon collaterals that were involved in the damage. Direction of degeneration. Wallerian degeneration is anterograde degeneration, meaning the degeneration is always from the injured site away from the cell body. An example, if an axon is cut, the part distal to the cut degenerates. Retrograde degeneration progresses from the injured site towards the cell body. This process is also known as dying back. The neuron will die if the degeneration reaches the soma. Wallerian degeneration creates a microenvironment conducive for axonal regrowth and reinnervation. This process takes place within the first week after injury when the typical markers of axonal damage occur, such as the loss of cell membrane integrity and the breakdown of the axonal cytoskeleton. Wallerian degeneration process. With Wallerian degeneration, eventually the axon deteriorates. The membrane breaks apart and the myelin sheath degrades. Then microphages arrive to clear the debris. Anatomy of a neuron. In order to understand the classifications of peripheral nerve injuries, you must first be familiar with the anatomy of a neuron and the organization of the connective tissues that holds the axons together. The nerve injuries we're going to cover affect myelinated neurons. A nerve is a bundle of axons in the peripheral nervous system. The organization is that individual axons are wrapped in myelin, then covered with endoneurium connective tissue. Then, bundles of myelinated axons wrapped in the endoneurium are then bundled together and surrounded by another connective tissue called perineurium. These groups of bundled axons are called fascicles. Then, groups of fascicles are bundled together and surrounded by another connective tissue layer called epineurium. Sedan's classification of nerve injuries. There are 3 degrees of nerve injury according to Sedan's classification of nerve injuries. Going from mild to severe, the order of nerve injuries are neuropraxia, axonotmesis, neurotmesis. I need to stress that these nerve injuries affect the axons within a whole nerve. Therefore, the loss of whole nerve function is dependent on the number of axons injured within the whole nerve. Neuropraxia is the mildest form of nerve injury. Only the myelin is affected. That doesn't mean it's not painful. If you've ever had a burn or stinger, you know what I'm talking about. This type of injury is considered a functional injury because it only causes temporary block or transient block of motor and/or sensory nerve conduction. Transient loss of motor function is more common than the loss of sensory function. This type of injury does not lead to nerve degeneration and is usually reversible. With neuropraxia, there's focal demyelinization at the injured site, but the remainder of the nerve is intact. A neuropraxia type injury does not damage any neurons nor any of the connective tissue layers, such as the epineurium, perineurium, and endoneurium. They all remain intact. Neuropraxia type injuries are caused by compressive injuries leading to ischemic conditions and/or traction type injuries. Some examples of compressive injuries is mild entrapment and subluxations. The CAT scan images are demonstrating entrapment of the C1 nerve root due to an upper cervical subluxation. Burner-Stinger syndrome. A Burner-Stinger is a perfect example of an acute neuropraxia type injury. Burner stingers can be caused either by a traction or compression injury. This type of injury is common in contact sports such as football. A burner stinger affects the C5 or C6 nerve roots. The burner can occur with acute traction to brachial plexus from the ipsilateral shoulder depression combined with contralateral neck flexion, or a direct blow to the supraclavicular fossa, or compression of cervical roots or brachial plexus from the ipsilateral lateral flexion and hyperextension. I posted a video called Burner Stinger that demonstrates this type of injury during a football game. Axonotmesis is the next level of injury. It is more severe than neuropraxia and not as severe as neurotmesis. This type of injury damages both myelin and axons without damaging any of the connective tissue layers. There is complete loss of nerve conduction distal to the injured site. That means no sensory or motor signals can be received or sent, respectively. Keep in mind, this injury is referring to damage to axons within a whole nerve. Therefore, if some axons within the whole nerve escape injury, they still could transmit signals, albeit weak. Whenever an axon is damaged, there will be degeneration from the injured site away from the neuron cell body, called Wallerian degeneration. Axonotmesis or axonotmesis, I really don't know how to pronounce this word, but I know what the type of injury it is. This type of injury will result in motor and sensory dysfunction of the tissue and/or structures innervated by the injured nerve. Depending on the number of axons damaged, this type of injury can lead to atrophy of the affected muscles. In addition to the clinical signs of muscle atrophy, a patient with this type of nerve injury will have decreased or absent deep tendon reflexes of the affected nerve roots. Axonotmesis type injuries may recover spontaneously, again depending on the number of axons damaged. the age, and general health of the injured patient. Sometimes this type of injury requires surgery to remove a structure that is causing the axonmesis, such as spinal stenosis or a disc herniation. Neurotmesis is the most severe type of nerve injury. This type of nerve injury involves partial or complete severing of the nerve, meaning some or all of the axons are completely divided. This type of injury can be caused by severe traction that tears the axons apart, or severe compression that completely crushes the axons, or complete transection of the axons. As you might expect with neurotmesis, there's an immediate sensory and motor loss with this type of nerve injury. There will be complete paralysis of innervated muscle or muscles and eventual atrophy. Also, complete numbness of the cutaneous region supplied by the injured nerve. There will be Wallerian degeneration distal to the injured site and possible retrograde degeneration as well. Recovery from this type of injury will require surgery to line up and attach the damaged ends of the axons together. Even if a surgical procedure is successful, sensory and motor deficits may still persist. Steps in peripheral nervous system nerve repair. First, I want to say the Schwann cell plays a major role in the repair of an injured nerve in the peripheral nervous system. Schwann cells differentiate to take on a new role over just producing myelin. These cells are the single most reason peripheral nerves regenerate, whereas CNS nerves rarely regenerate. The steps in the peripheral nerve injury repair are: number 1, Schwann cells recruit more macrophages to clear the debris caused by the degenerated axon. The axon cannot begin to heal until all the trash is removed. Next, the differentiated Schwann cells form a hollow tube called the bands of Bugner around the axon stumps. This tube provides a pathway for the regenerating axon stumps to grow towards each other. At this time, the Schwann cells will produce neurotrophic growth factors that stimulate the growth of the Schwann cells themselves, but will also stimulate the growth of the neuron. The proximal stump can pick up these neurotrophic factors and transport them back to the neuron cell's body, which will stimulate protein synthesis, leading to regrowth of the proximal stump. The proximal stump will send out sprouts within the hollow tube created by the Schwann cells to reconnect with the distal stump, thereby reconnecting the severed ends. Peripheral nervous system nerve repair. If the sprouts from the severed proximal end reach the distal neurotubules, it will grow and advance. The key to healing an axonmesis type injury is for the stumps to align and the neurotubules to reconnect. That's what makes the role of Schwann cells so critical to the healing process. Peripheral nervous system nerve repair. If most or all of the nerve is severed, surgery will be required to reunite the neuron tubules. Schwann cells will still perform their same role in the healing process if surgery is used to align the severed ends. Regeneration of an axon in the peripheral nervous system is efficient because of the Schwann cell function. Regeneration of axons in the CNS can occur, but is minimal due to the lack of Schwann cells.